Thank you so much, Brooke. I just want to thank you for this really kind invitation to talk tonight. I'm really excited to be here. So thank you so very much. I'm going to attempt to share my slides. Just get these in presentation mode. All right. So welcome everyone. My name is Vicki Lewis. I am a speech language pathologist by training. These are my disclosures. I do receive a salary from Aspire Respiratory Products for my work there as an educator. And I am receiving an honorarium from TIMS for speaking with you all today. So let's dive right in. What is respiratory muscle strength training? And I always feel like when I talk about this topic, I throw around so many acronyms. It kind of turns into alphabet soup. So let's break down the soup. So at the top, or the umbrella, as I like to call it, is respiratory muscle strength training, RMST. And that's the process of building strength within the muscles or the muscle groups that control our breathing. Underneath that big umbrella of RMST, we've got IMST and EMST. IMST, Inspiratory Muscle Strength Training, where we're targeting the muscles of inspiration. So we've got there the diaphragm, the primary muscle there, as well as the external intercostals. And then we also have EMST underneath that umbrella, Expiratory Muscle Strength Training, that addresses the abdominals and the internal intercostal muscles. And also, we learned several years back, but we didn't know this at first, that there is an impact on the submental muscle group. And we'll be talking about that in more detail coming up here. Here is an image of the respiratory system, and I feel quite confident that you all could identify all of these structures. You don't need the labels. But the reason that this is here is, although respiratory muscle strength training is targeting these muscles of respiration, that muscle function has an impact on this entire respiratory system. So the goal of RMST is to increase the force generating capacity of these respiratory muscles. And so it's either the inspiratory muscles or the expiratory muscles, depending on which group is being addressed in the treatment. And this is it's a specific exercise. And the thing that sort of interested me the most when I learned about RMST, and I think I first heard about it in 2009, and a dear colleague of mine and I were collaborating about a challenging patient. And my colleague said to me, well, I think he would benefit from EMST. And she may as well have said he might benefit from MOUSE. I had no idea what she was talking about. But I quickly learned and really dove into the literature and really just sort of indoctrinated myself into this added tool that I could add to my clinical toolbox. And I found that so exciting. It really satisfied my inner nerd. So how does RMST work? RMST is a high frequency, high resistance task. It is a sprint. It's not a marathon. And these next two dot points on this slide, I'm going to talk about them, but I also want you to know that these are not chiseled in stone. They can be changed. In the research literature, however, the majority of participants in these studies did this task at about 70 to 75% of either their maximum expiratory pressure that they could generate, otherwise known as the MEP, the MEP, some more alphabet soup, or their maximum inspiratory pressure, their MIP, their MIP. And this task is completed 25 times. And it says here 25 times a day, but it's 25 times in one sitting. the training should not be spaced out throughout the course of the day. Patients get the maximum benefit, again, with this high frequency, high resistance task. But this is not a cookie cutter approach. So I don't want anyone to kind of have blinders on and be like, okay, this is what we have to do. And if the patient can't do this, then we have to forget about it. We can do this type of training at less than 70 to 75% of a patient's maximum. And they may have to start out with this training with doing less than 25 repetitions because they may not be able to do that. And so you can start the training and then build them up. So again, just want to point out, this is what's in a lot of the research that's published, but again, it's not mandatory. This last point on the slide with the star by it, I always say as speech language pathologists, we don't talk a lot about bowel movements, although I don't know about you all, but some of my patients have tried to tell me about them. But when you're talking about patient candidacy for respiratory muscle strength training, is this patient a candidate? Is this safe? This is a great talking point to have with physicians and other care providers. Typically, there is less intrathoracic and intracranial pressure generated with this training than is produced during a bowel movement. But you do have to also consider the number of repetitions, which is a little bit different than a single bowel movement. This is some normative data. By no means do you need to memorize this. And there are, dare I say, bazoodles, I'm making up words. There are bazoodles of norms out there, and they're not all identical. And if you look at this normative data, it starts at age 20. And if you work with pediatric patients, this information won't do you much good. But there are multiple sources out there for pediatric norms as well. And I think when we work with patients and we're utilizing respiratory muscle strength training, it's nice to know what normal is. But I do think we also have to consider that our patients, with their disease state, they may never get back to normal. And it may have been a long time since they would have had these normal scores. But it's a nice frame of reference. And here you can see that our strength declines with age. It's always a little depressing to look at this. And then you can see the different ratings for male and female. So again, I don't think you need to post this anywhere. It's just a nice frame of reference. And certainly out there in the literature, you can find plenty of different sets of norms. So let's talk a little bit about respiratory devices. And on this slide, on the left, you see an incentive spirometer. And if you have spent any time in a medical facility, you've probably seen an incentive spirometer on that bedside table of nearly every patient that you've taken care of. And then on the right-hand side is an EMST 150 device, and it is an Aspire device. I don't work in sales, but I have the easiest access to Aspire's images. So I'm just you'll see some more Aspire images as well. But I would like to talk about the different devices that are available out there. So the incentive spirometer is a device that is designed to keep the lungs inflated. It's designed to prevent atelectasis. And really the end goal is to prevent pneumonia. It's a great device. Respiratory therapists typically utilize this device. Nurses train patients on how to use this device. It does not, however, strengthen the muscles of respiration. So in my outpatient settings, I've talked with patients about respiratory muscle strength training, and they've said, oh, I think I have one of those. And I always say, okay, next time you come, bring it in. And they would always bring in their patient belonging bag from the hospital, potentially never opened. And they would open it and they would pull out an incentive spirometer, which unfortunately was not what we needed for the treatment that was being recommended. Now, when we look to the right here, we see that EMST 150 device, and that is a pressure threshold device. And the majority of research articles out there on respiratory muscle strength training for IMST and EMST have been completed with threshold devices. And you can, when you read a research article, you can look to see what device was utilized. But there are other devices available out there as well. So I'd like to talk about those. There are what are called resistive trainers. And those are a bit different than a pressure threshold device. Speech language pathologists have been using resistive types of exercises for years and years. Think about pursed lip breathing, right? We're changing the space through which air can flow. Think about rescue breathing with a straw for patients who have vocal cord dysfunction, VCD. But what resistive or resistance trainers do is they restrict the flow of air. So think of, a large diameter hole and then a smaller diameter hole. And so as a dial is turned on that device, the space gets smaller. And these trainers are impacted by airflow rate. And so the patient can actually vary their airflow rate, not intentionally, it's just something that happens. And so with resistive trainers, it's a bit of a challenge to maintain the pressure from breath to breath and even throughout one breath. But a pressure threshold device is a bit different. And let me just check my next slide here. Yeah, let me just kind of show you this pressure threshold device. And not just the Aspire products, there are other pressure threshold devices out there on the market. But they have a rubber diaphragm or a valve on the inside. And if you have an EMST device, an EMST 150 or 75 device, you can kind of put your fingers, and there are little, you can put your pinky finger in the vent, and you can feel this rubber gasket, and it goes the whole way around. Right in front of that gasket on the inside of the device is a spring. And when you turn the adjustment dial on the device, it pushes that spring up against the rubber diaphragm, holding it in place. It's a spring-loaded valve. And so the patient, when they're blowing through the mouthpiece, they have to generate enough force to blow that valve open. And they have to maintain that force throughout a breath and from breath to breath. So that's what makes it a pressure threshold device. Here are a couple of the devices from Aspire. I had mentioned and pictured on that last slide was the EMST 150. The number of the device tells you how high the device setting goes. So this device goes up to 150 centimeters of water. And that centimeters of water, that's a measurement, I think, as speech language pathologists, we don't think about a whole lot, or we don't hear a lot about it. But in the respiratory literature, you will see that measurement quite frequently. Although the 150 device goes up to 150, it doesn't have a true zero starting point. It starts at 30 centimeters of water. So if you have a patient who's very debilitated, maybe just a very debilitated outpatient or someone in acute care, there's a good chance they're not going to be able to generate enough force to open this valve. And years ago, the EMST 150 device was sort of all we had. And now there's the EMST 75 that starts very close to zero. It only goes up to 75, but it has that much lower start setting for your patients who aren't able to generate enough force to open a valve with a set at 30 centimeters of water. The EMST 75 device from Aspire does have a HCPCS code for billing purposes for Medicare, which I feel like is worth mentioning because it may make the difference for a patient to be able to obtain the device. At the bottom there is an inspiratory training adapter. And this device, if you look at the picture there, you can see the device, and then you put the EMST device into the adapter to turn it into an IMST. So if a patient needs EMST and IMST, you can accomplish that with this adapter. There are other companies too. They don't make adapters, but they make designated inspiratory muscle strength training devices as well. So if it's something you're interested in, there's a lot to explore. Here's a slide, and I always say this slide has a lot of words. And if you take a look here, there are different sort of conditions or diseases listed, and these are all issues, if you will, that have been investigated and published in the literature. And the individuals that fall into these groups have been found to benefit from either IMST, EMST, or potentially both. And I think sometimes if we come across a patient who could potentially benefit from both, I think it's a really good idea to look at their clinical deficits as a clinician and sort of decide where to start. I always say what will give the patient the most bang for the buck. And certainly, we consider those patient populations, and let me just go back to this. If you look at this and you're like, well, I have a patient and I don't see their disorder on this list, so I guess I can't consider respiratory muscle strength training. I would say maybe change your line of thinking potentially. There are so many, especially neurological disorders, that have such similar symptoms. These patients have similar deficits. And sometimes if a patient has a relatively rare disease, it may not be studied. But that doesn't necessarily mean that they can't benefit. On this slide, I wanted to point out that you can also think about respiratory muscle strength training in terms of having an influence on the future. There are some studies out there showing the completion of RMST, either EMST or IMST, prior to a hospitalization, a planned hospitalization, a planned surgery, quite frequently, to strengthen muscles with the understanding that this patient is going to have a prolonged recovery, potentially a prolonged hospitalization. And sort of coordinating with physicians in their outpatient clinics to potentially identify these patients could be a worthwhile expansion of your services. These are just some article titles that I just took some screenshots of for pre-op, pre-treatment populations to consider. On this slide, we've got a training protocol, and it is just that. It is a training protocol. It's not the training protocol. But Dr. Christine Sapienza at the University of Florida did a lot of the foundational research that we have on EMST. And Dr. Sapienza and her colleagues used this protocol based on 5. It was a 5-week program. The patients complete the training 5 out of 7 days a week. They do 5 sets of 5 breaths. That's that 25 breaths that I spoke with you about. And again, if they can't tolerate this protocol, that doesn't mean you do nothing. You can alter this protocol. It is not chiseled in stone. There are other studies out there published in the literature, though, where other training protocols are utilized. I've seen, 6 sets of 6 repetitions done twice a day. Some of the literature, the publications out of Australia and Brazil, there are different protocols out there. My thought is this: I don't necessarily feel like I need to be married to a protocol, but I do want to try to either follow a protocol or work my way up to a protocol that has been studied. So I want to make sure what I'm doing is evidence-based whenever possible. To the right here is the mention of the maintenance program. And with this, just like if you go to the gym and you exercise and the definition of your muscles changes, but then you stop going to the gym, eventually those skeletal muscle changes are going to go away. And that's what our respiratory muscles are. They are skeletal muscles. And if we stop this respiratory muscle strength training and we just put the device in a drawer and forget about it, we're going to lose the strength that we gained. And so we put these patients through a program, and maybe it's 5 weeks, maybe it's more than that. But eventually, when they no longer tolerate an increase in the threshold setting, they've sort of maxed out. And every patient's max will be different. You know, just because the device goes to 150 doesn't mean that all patients are going to get to that level. But once they've maxed out, we can put them on a maintenance program, and they're no longer going to adjust the setting on the device to increase it, but they're going to complete the training 2 to 3 times a week. They're still going to do 5 sets of 5 breaths 2 or 3 times a week to work to maintain the strength that they built. So when we're thinking about this training, you know, what are we trying to address? Well, cough strength is the first one listed here. And you can address cough strength 2 ways. You can do it by increasing inspiratory strength, because then with that, there'll be more air coming in, and it's going to increase the lung volume. So someone will have more air on which to cough. Then you could consider doing expiratory muscle strength training, because if you increase the maximum expiratory pressure, that's going to put a greater force on the air that's being exhaled when someone is doing the expiratory phase of a cough. And frankly, that is the more traditional way to address cough, is through using EMST, but it can be done with IMST. Then there's swallowing to think about, of course. And, you know, we all know that if we have a strong, effective cough, right, we can clear materials that at the very least are in the laryngeal vestibule. And, you know, we've known that for quite a long time. But then Dr. Karen Hegland at the University of Florida looked at ischemic stroke patients and noted an increase in submental force generation, which results in an increase in movement of the hyolaryngeal complex. And then as a result of that, an increase in UES or PES, whichever term you prefer, opening. Some other areas to consider: voice, increasing subglottic pressure. I've done a decent amount of EMST with patients who have unilateral true vocal fold paresis or paralysis. It has been found to increase maximum phonation time, perceptual changes, including reduced breathiness and an improvement in roughness, those aerodynamic and acoustic measurements. And also, this last dot point under voice is interesting to consider. When you work with patients who have vocal cord dysfunction, VCD, or paradoxical true vocal fold movement, I know I use a lot of the cognitive behavioral strategies that Dr. Florence Blager taught all of us. And sometimes that's all my patients need, but sometimes I just can't seem to get them to the finish line despite treatment and medical management. And IMST has been found to increase the synergy between the diaphragm and the posterior cricoarytenoid muscles, promoting true vocal fold abduction. So use of IMST with that particular patient population has been published and has been found to be effective. And in my own experience, I have seen it do some really amazing work. The last one listed here on this slide is speech. There are some studies, although less of them out there. So certainly if you're interested in conducting research, the literature needs you. But speech intelligibility and even inducing activity of the lip muscles and potentially strengthen the orbicularis oris. So let's talk a little bit about where do we start and how do we do this? And for some of you listening, you may already be aware of all of these things, but we can get formal measurements of a patient's maximum inspiratory pressure or maximum expiratory pressure if we have some type of respiratory device that will measure pressures. Now, most speech language pathologists don't have this device. It's not available, and oftentimes it's cost prohibitive, and disinfection can be complicated. It is necessary, though, to have these formal MIP and MEP measurements if you're doing research. But from a clinical standpoint, we can get by without having these formal measurements. And so I'd like to talk about that just a bit. So where do we start with this? How do we determine that threshold setting? You know, how are we going to initiate training? And with this, we've got a list of tasks here on this slide, and you can find this on the Aspire website as well. But what I always want to do when I start working with a patient, before I get to this, before I'm going to figure out where are we going to start our training, I want to teach the patient how to use the device. And I want to see what works best for them. So finding out what mouthpiece is best for them. Which one is more comfortable, and or which one can they get the best lip seal with? And so even though I have my own favorite mouthpiece, I like the oblong mouthpiece, and there for a while I had a tendency to put that one on, and that's what the patient would use. But I think trying both mouthpieces is really important. And other devices may come with other mouthpieces. You know, just try what's available and make sure you can find the one that's the most comfortable and the one where they can achieve a lip seal. Teaching the patient how to blow through a device. Now, I'm going to show you with the EMST 150 device, but it can truly be any device. If you're doing expiratory muscle strength training, you want the patient to blow through a pressure threshold device quickly with as much force as they can, like they're blowing out a candle. So it looks like this. And if you notice, I blew through the device, I took the device away, and I finished exhaling. That finishing of the exhale is very important. If you don't finish the exhale and you blow, if you do it quickly, you'll get dizzy because you're not blowing off the carbon dioxide. And the patients may even say like, oh, I don't want to do that. It makes me dizzy. And so really important that they're knowing the right technique. And then you can take them through these steps where you start a device at its lowest setting, have the patient blow through it, make sure they've got the technique, and then increase that device dial slowly by typically about a quarter of a turn. Have them blow through the device. Keep going, keep going, keep going until they can no longer blow through the device. Now, a lot of the device instructions will tell you once you're there, turn that dial back a quarter of a turn and then begin the training. Most patients that are being seen by a medical professional, however, don't start their training there. I usually try it there, do a full training set, and then adjust it to a lower setting as needed, depending on their performance. And then increasing the device threshold setting, if it's an outpatient, about once a week by about a quarter to a half a turn. And training the patients how to accurately do that, or their caregivers, if at all possible. In acute care, I have found that I tend to increase the device setting more frequently, but by a smaller amount. And again, it's much more important for a patient to do all of the repetitions rather than have the device at a high setting. And so I always tell my patients, please don't be like Arnold Schwarzenegger and go home and crank this device up. And then you can only do one set of 5. The repetition is important. So finding that just right setting. Precautions and contraindications. I spend an awful lot of time talking with people about their specific patients. Now, there are some hard no's when it comes to respiratory muscle strength training. Pregnancy is a hard no. At least I can say that for the Aspire device. It hasn't been studied in individuals who are pregnant. Another hard no is uncontrolled high blood pressure. Now, if a patient has hypertension, they take medication, it controls the blood pressure, that's totally fine. But for patients who are in some type of hypertensive crisis, it is contraindicated. Patients who have any type of abdominal herniation, and when you're talking about safety, thinking about, the pressures that are being generated. So if you're doing EMST, it's basically like a Valsalva. And talking again with the physicians. I think especially if you're just starting a program, having those conversations is really important. And we can't assume that all physicians are going to know what we're talking about when we talk about inspiratory muscle strength training or expiratory muscle strength training. We may be the ones having to give them the information, but having that dialogue where you can provide the information is so crucial. Here is my interpretation of this situation. So on the far left is the doctor telling me no way, when I haven't even fully gotten all of the words out of my mouth. And then on the far right is also not exactly what I want either. I don't want them to just throw me the keys to the Ferrari and say, oh, I trust you. Just do whatever you want to do. As badly as I would love to drive a Ferrari, what I do like is the X in the middle here, somewhere between no and do whatever you want. I want to have a dialogue. And having a physician champion, if you're just starting a program, is also a really good idea. A physician who understands what this is, what you're trying to accomplish. Maybe they'll kind of begin with the referrals, and then other physicians may follow suit after seeing good results potentially. So just having that dialogue. So RMST is not a one-size-fits-all therapy type of program. We can, as I mentioned, we can change the training schedule. We can customize the training based on the patient's needs. We can customize the mouthpiece, and we'll talk about that in a little bit. And just because we have respiratory muscle strength training doesn't mean that we abandon all the other therapeutic exercises or strategies or other things that we know. It's just another tool to add to the toolbox to try to promote patient success. Some slides that cover some things to think about. So when you're doing respiratory muscle strength training, think about patient positioning. And if you have a patient and you're thinking, okay, well, the patient's in a bed and their positioning is not optimal, positioning the patient for success. And maybe you can co-treat with PT or OT or just collaborate with nursing. But thinking about even an outpatient, and maybe it's even a fully independent, as we call them, a walkie-talkie outpatient, and you have them bring their device in and, how have you been doing? What have you been doing? And they are all slouched down in their chair and they're doing their exercises like this, right? We want good upright posture, right? We want that chest cavity to be able to expand as much as possible. Also, I think about patient positioning from a safety standpoint as well. Remember how I said if patients aren't fully exhaling after doing expiratory muscle strength training, they may become dizzy. And so in that case, I don't like them to stand to do this training. I like them to sit comfortably, but upright. The timing of treatment, thinking about patient alertness, patient endurance. Did they just have physical therapy and they need to rest? Are they not alert in the mornings? You can decide what time of day to do this training. The other thing to think about, I think, is medication administration. If it's, pain management or symptom control, thinking of like Parkinson's disease, for example, or their alertness. Maybe they have periods of confusion and agitation and they have to be sedated, figuring out, okay, what time of day does that typically happen? When are they at their most alert? When are they in their most alert state? Thinking about other interventions that are happening, I think, is also so important. And this first dot point here, tube feedings, is a biggie. And it's not listed when I talked about contraindications and precautions, but I think about patients who just had a PEG tube placed. When is it safe to either reinitiate or initiate for the first time training? And again, that's a conversation with the physician. But thinking about tube feedings, we are potentially putting pressure on the abdomen, putting a patient at risk for reflux if their belly is full. And so thinking about tube feedings, is this patient receiving bolus feeds? Are they receiving continuous feeds? Do we want to talk with the physician about stopping continuous feeds for 30 or 45 minutes before doing this training? How long after a bolus feeding, or time it before bolus feedings are initiated to minimize the risk of reflux? Thinking about all of the other care, all the other interventions these patients are receiving, timing things with nursing care, if that's the patient population that you're working with, if they are more acute. Also thinking about oral care and moisturizing the mouth. I'm not sure how many of you have done a full training set, 5 sets of 5 breaths, but quite honestly, with inspiratory and with expiratory muscle strength training, all of that airflow can have a tendency to make your mouth feel a little bit dry or your throat a little bit dry. And so having water available, if the patient is permitted to take water by mouth, or figuring out a way to moisturize the mouth, maybe with an oral swab or some moisturizing products to maximize their comfort. And I apologize, I'll fix this slide when you get it. I was gonna kind of do more device demonstration at the end, but I sort of did that already. But making sure that a patient is utilizing the device accurately. And when I say this, I want to just kind of share my own experience. Like, I have spent, lots of time with patients, teaching them how to use the device, having them demonstrate it, having them show me, do a full training set before they leave my office as an outpatient, or, before I leave their room as an inpatient. And then when I see them again, I never want to assume that they've got it. Because I've had them come back, even, patients without any cognitive deficits come back in and show me how they've been using the device. And it's very much a facepalm moment, because I was like, I really thought they had this. Sometimes using the technology is helpful. So maybe, if they want to videotape me on their phone, or have me videotape them on their phone, using the device, so they have that to take with them. Those moments when you get home from I don't know, a physical therapy appointment or any type of medical appointment, and it all made sense while you were there. And then you get home and you're like, oh, what was that? So making sure people are using the device accurately. Looking for hamsters. Sometimes patients blow their cheeks up with air, and that's not what you want to see happening. And so if you do see cheeks full of air, using digital cheek support. Nasal occlusion Most devices come with a nose clip, and most patients don't want to wear them, and I don't blame them. They're not very comfortable, in my opinion. If a patient has intact velopharyngeal closure, they don't need a nose clip. Unless there is some sort of condition that's causing nasal escape of air, they're fine without it, usually. And I'll explain one caveat. Um, if the patient doesn't blow their cheeks up with air, they're not using their hand to support their cheeks, they can just digitally occlude their nose, which is usually more comfortable. But if they are blowing their cheeks up with air and they need to occlude the nose, then the nose clip needs to be utilized. The only other time I have used a nose clip with a patient who didn't seem to have any nasal escape of air was kind of like really high level patients, but potentially athletes. And we're getting the device setting up there pretty high. And we're trying to increase the threshold setting, and they're just not tolerating it. Sometimes I'd have them try with the nose clip just to see if it made any difference. Getting that lip seal on the mouthpiece is crucial. You can also use digital occlusion with the lips, or train a caregiver to do that if needed, or you can modify the mouthpiece. Our wonderful colleagues, and some of whom may even be here tonight from respiratory therapy, just like they help us out with the passe-mur valve and attachments, you know, they've got like just these magical things in their respiratory therapy bags. So sometimes they can switch out device mouthpieces. You know, we've got the two in the middle there that we've already looked at tonight, but in the far left is a snorkel mouthpiece that is commercially available. And this is a great mouthpiece for patients with a significant amount of oral weakness, for example, ALS patients. And I once had a patient, she couldn't use any mouthpiece that I had in stock. The snorkel didn't work for her either. So what I did, and I've got this purple line here, I took a scalpel. I was at an ENT practice, so scalpels were easy to come by. And I cut the snorkel off, and I just used this large round rubber end. And I put the end that I cut away from where her mouth would be. And this end is quite smooth and tapered. And she was able to use the device, and she didn't have to really close her lips down. It was mostly just right where she needed it to be. All of this to say, you can get very clever. And if any of you ever have questions about mouthpiece modification, my email address is on the last slide here, and I would be more than happy to talk with you. A couple of frequently asked questions. Do I need to be certified to do respiratory muscle strength training? No, there's no certification. However, I do recommend attending a training course that will give you an opportunity to learn more and utilize devices yourself. My patient reports their device keeps sticking or it's making a sound. What's happening? So if they are using an EMST device and it starts to squeak, it kind of goes, that was interesting, but it makes this squeaking noise. And oftentimes when we hear that, like if we start hearing like almost like a Canada Goose sound with a passe-mur valve, we know the valve is going kaflooey. But that's not the case usually. What the squeaking sound for EMST usually means is that in a pressure threshold device, it means they're not generating enough force to blow the valve completely open and keep it open. So it's usually a patient technique problem, or the threshold setting is a little too high. For Aspire devices, for the IMST adapter, this actually does sometimes honk. And if it's happening intermittently, it's just an artifact of the device and nothing to panic about. If it honks repeatedly and consistently, the device, the threshold setting on the device that's inside of it may be a little bit too high. But again, happy to assist with any of those questions. You can always feel free to reach out to me. We're always talking about a quarter of a turn of the dial. So can I adjust the dial on a device by less than a quarter of a turn or more than a quarter of a turn? Absolutely. In fact, when I'm determining the training threshold for a really strong, healthy patient, I might increase it by a half a turn at a time just to get there faster. Is it okay for my patient to complete the breaths rapidly? Probably not. If they're doing that, they're probably not fully exhaling. And so that should be avoided. Now, we don't want them to go super slowly either. Remember, it's a high frequency, high resistance task. But it's okay to pause in between breaths. But that really rapid pace usually leads to problems. Other than speech language pathologists, what other disciplines can use RMST? I have talked with physical therapists, some occupational therapists even, respiratory therapy and speech pathology. A lot of times too, if you have patients who might be doing both IMST and EMST at the same time, it's possible that speech language pathology can't get there for long enough or enough times a day to do that. And so collaborating with respiratory therapy or potentially PT or others can be really beneficial for patients and can really expand programs. All right. So my hope was to present just kind of a basic case, but one that would cover some different areas. And so it's not super detailed, but I did want to share this with you and then would love to answer some questions. This is a patient that I saw in an outpatient setting. He was 61 years old. I'm not going to read all of this to you, but if you just kind of scan his cervical spine and upper thoracic spine history, it was a showstopper. This gentleman had been through an awful lot, and he was dealing with quite a lot of issues, unfortunately. He did end up with transient, or what they called transient, right vocal fold paresis following his second anterior approach surgery. And when I saw him, he reported that he had been experiencing fluctuating dysphonia and vocal fatigue since that second anterior approach surgery. So although they called it transient, his symptoms weren't transient, they had persisted. He had a past medical history of gastroesophageal reflux and laryngopharyngeal reflux. He had been just switched over to taking Nexium when I saw him. He had been on that for about 4 weeks. Prior to that, he had been taking Acifex, but his insurance had stopped covering it. He was taking the medication 1 to 2 hours before breakfast, which was not optimal, so we did talk about that. He also had a history of sleep apnea and utilized CPAP. So when he came in to see us, he was referred by otolaryngology. He reported some symptoms of dysphagia, primarily with solid consistencies, would experience some coughing after primarily swallowing solids, and he complained of a sensation of particles sticking in his throat. He altered his diet just a little bit to avoid dry particulate foods, but otherwise was taking a regular consistency diet with thin liquids. He reported that history of dysphonia, as I mentioned, and with further questioning, he was experiencing vocal fatigue. He had a hard time being heard over background noise and also by his wife, who had some reduction in her own hearing acuity. He was receiving physical therapy, occupational therapy, massage therapy, and was also being followed by a pain management specialist. So to my ear, and with use of the CAPE V, he had mild dysphonia with roughness and breathiness evident in conversation, and had quite a bit of glottal fry. These are just some still images of his laryngeal video stroboscopy, but on the left and on the right as well, but I think the left shows us better. This was his maximum glottic closure. He's got some posterior irritation here, possibly the beginning of some granulation tissue. And you can see too a bit of lateral compression of the ventricular folds there. So those were the still images from his stroboscopy. Based on his swallowing complaints, we did send him to our trusted hospital for a video fluoroscopic swallow study. Thankfully, nothing too terribly surprising there. Noticed the narrowing at C6 and reduced space in the piriform sinuses and within the cervical esophagus, and also some pharyngeal dysfunction. It was recommended that he could continue on his current diet, but to alternate solids and liquids and utilize multiple swallows and a cough re-swallow with thin liquids. Dysphagia therapy was recommended, which we initiated, along with some voice therapy as well. So again, we didn't just do EMST. We did EMST, and then we did the other things that we knew to attempt to come at this from all angles. With his completion of EMST, he started close to 40 centimeters of water. That was his initial threshold setting. And then over the course of 5 weeks, he got almost not quite to 80. So definitely, improved performance there. This was a still image from his repeat stroboscopic exam. And you can appreciate the irritation is still there. I think the reflux is probably still an issue. But the glottic closure, in my mind, was definitely improved. It's complete. There's no longer a glottic gap. And there's some reduction in the lateral compression, that supraglottic hyperfunction. The patient had improved vocal intensity. He had reported he was able to speak better over background noise. He reported an improvement in vocal fatigue, and his glottal fry was minimal. His score on the voice handicap index had improved, and he had heard, and to me, this is better than the VHI, positive feedback about his voice from friends and family. From a swallowing perspective, he reported less coughing. And when his cough did occur, he felt like he only had to cough once and he could clear the material. He was no longer experiencing the sensation of food sticking in his upper throat region, and his EAT-10 score improved. I did ask him to consider doing a repeat modified barium swallow study, not because I felt like, okay, things have likely improved, but I thought it would be a nice thing to have sort of as a new baseline with knowing his condition and how things might worsen. But he declined, and I completely understood. But we did have those perceptual improvements. So with that, it got me thinking about some treatment outcome measures, and I just wanted to share those thoughts with you. People are like, well, how do I know that, the training is working? Well, you can know that function is improving by the increases in the device, whether it's for EMST or IMST. You may find instrumental assessments that reflect changes. I don't know that I would necessarily recommend, like with this last case, like it wasn't like, no, we have to do another modified. In some cases you do, though. If you have a patient who has significant deficits and they're on a modified diet and you're wanting to upgrade it, it'll help you to make those judgment calls, but also let you know what the treatment has been doing. But, a repeat MBS, a FEES, a repeat strobe if you're working on voice, and even peak flow meter measures that measure cough strength. You could measure it that way. Perceptually, patient scales, the voice handicap index, the EAT-10, the Lessiter cough questionnaire, talking about cough effectiveness. And if you're working on breathing, maybe with the IMST, looking at the modified Borg dyspnea scale potentially. So just some things to kind of keep in mind, keep in your back pocket, if you will. These are the references. This is my email address. Please do not hesitate to reach out. I would be more than happy to try to answer any questions. And I'm going to stop sharing my slides here.
Thank you, Vicki. That was amazing. Just a couple of housekeeping items real quick before we go into Q&A. And I did put this in the chat, but just a reminder, if you are wanting ASHA CEUs for this presentation, please fill out the survey that was included in the chat. And if you can't access it because you're on your phone, no worries, it will be sent out via Zoom after this session concludes. And then if you'd like a certificate of completion, just send us an email at tim@univ.com. And the replay will be up on our website within 48 hours. So with that, I'm going to go ahead and pull up some questions. Okay, the first one is, in outpatient settings, do you have the patient purchase his or her own device and bring it to the therapy session?
That is a great question. I think it depends on where you work. And so I know I have the pleasure of talking with people all across the country and sometimes all across the world. And there are outpatient clinics where the patients do just that. They purchase it and they bring it in. There are other settings where it can be provided. It really just depends on the way items are billed. If you're in a larger clinic where, say, you've got PT and OT, I always ask, and it's not like I want to pick on our OT friends, but I'm like, how did the patients get reachers? Because it's about financially equivalent. And I'm like, if you're giving away reachers, then I'd like to give these away. But if you're not, how are you billing for them? How are you getting them? It's sort of kind of copying maybe what other rehab professionals are doing with similarly priced devices. So just a thought.
Okay, Vicki, that is so cool. I've never heard that recommendation before, but I love that. Um, okay, the next question is, for SLPs in the hospital setting that carry both EMST 150 and 75, is there a quote unquote screening method that is cost effective that we can use to determine the correct device so that we are not starting them off on the wrong device?
Yeah, gosh, if we could come up with a cheap way to do that, I would be so happy. I always say check with your respiratory therapy colleagues. It's possible they have a device somewhere in a closet that they're not using, or that you could adopt. Generally speaking, I have never had a patient in acute care ever start anywhere close to 75 centimeters of water. So I feel pretty confident in an acute care setting, saying that the EMST Lite, the EMST 75 device is usually the safest bet. And a lot of times those patients don't get beyond the 75. And if they do, then they would have to purchase another device. But if they're getting the device through the hospital and they're not having to pay for that one, or if they're getting it through Medicare, and they didn't have to pay the full amount, I feel a little less guilty if they graduate, if you will. But in that acute care setting, I've not had anyone start at 75, and I've not had anyone get up to 75 in the time they've spent there. But I don't want to make a blanket statement because I don't know your exact patient population. But I don't know of an exact way to know unless the patient happened to have pulmonary function tests where you can see the MIP and the MEP in that report.
This is a great question, and I don't know if you'll be able to answer it completely in the time that we have, but it would be good just to hear your expertise. This person said, how can we as SLPs advocate for our facility to adopt EMST and IMST in the corporate hospital setting?
I saw that one come in. I was like, oh, that's such a good question. Sadly, money. Talking about the cost of an aspiration pneumonia, which last I looked, and this is an old study in chest, it was $60,000 was the approximate cost. But thinking about shortening length of stay, the sooner we can get these patients on this training and get them stronger, chances are we can get them out of acute care more quickly or out of the ICU faster, or we can have less days of tube feedings. It's a lot cheaper to feed someone food than it is to feed them via a tube. And it comes down to money. If kindness doesn't win the hearts of the corporate world, which it doesn't usually, but shorter length of stay, lower risk of aspiration, less days on tube feedings may be a good start.
Take a couple more questions and then conclude. this person said, is it recommended that you wait to start RMST with acute CVA population?
Great question. I'll make a couple of general statements, but again, I always go back to talk to the physician and talk to the physician that's most relevant. So neurology or neurosurgery, depending on the situation. Generally speaking, I would be concerned with an acute hemorrhagic stroke patient because remember I mentioned there's intracranial pressure being generated. But in my facility, we had an advocate who was a neurologist, and he cleared us to see most ischemic stroke patients. But again, you want to look out in that stroke population too for high blood pressure, for sure. But it's definitely worth a conversation. And as I mentioned, my acute care hospital, we did see ischemic um, uh, acute stroke patients. We did not see acute hemorrhagic stroke patients because of that risk.
I see a lot of questions about MIP and MEP and different devices, as well as just quantitative measures in general. I did put a link to Dr. James Curtis's website in the chat. He has a ton of like great information and tutorials, so I definitely recommend checking that out because we won't have time to answer all these questions. But we'll do one more. Someone asked, how long do you wait status post ACDF to initiate EMST? And would you get clearance from the surgeon?
Yes, I would get clearance from the surgeon. And you know, those patients, those ACDF patients, they're all so different, right? You take them down to fluoro and you turn on the fluoro sometimes and you're like, oh my stars, like their posterior pharyngeal wall looks like it ate New York. Just a lot of swelling. But in other cases, not so much. And so I'd want to know like what was going on, and I'd want to talk individually with the surgeon that did the surgery. But it's definitely it's not a hard no.
Awesome. Well, Vicki, I really appreciate your time and expertise. If people have questions, because we didn't get to all of the questions in the chat, would you recommend that they reach out on the Inspire website or send you an email?
Yes, please feel free to send me an email. My email address was on that last slide. I can I can see about putting it in the chat perhaps. It's just it's Aspire Education, all one word, EMST150 at gmail.com.
Awesome. And I do know that they also have wonderful resources on LinkedIn and Instagram. So if you're on social media, be sure and follow them, and you can always send them a DM. And with that, we will go ahead and close out for the evening. If you have questions about CEUs, just send us an email at tims-univ@tims.com. And this replay will be up on the website, hopefully tomorrow, but at the latest in 48 hours. Thank you, Vicki, for your time, and thank you all for joining us this evening. Bye,
Thank
everybody.
you. Good night.